severely communicate fractures, about 15% of cases require surgical treatment either in the form of tense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is the tense nailing. Unlike preservative management, it provides stable fixation and early mobilization and reduces the risk of malnutrition. Tense is less invasive, resulting in smaller incision, reduced soft tissue damage and fewer potential complications, making it an attractive option for managing displaced fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, all were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, road traffic accident was the main mode of the trauma, whereas fall from height and fall on out-stage head was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI. And this is a typical clinical presentation, a bump at the site of the fracture, and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeter displacement, and the jet type of cognition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and screw. So these are the already explained. The simple fracture were taken into consideration. Displaced simple fractures, either spiral or oblique or transverse or short oblique, 15D1 and D2. The patient lies supine if we are affected, lip elevated, and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the reduction of the fracture by closed means. The incision, small incision, and a transverse or longitudinal incision about 1 to 1.5 centimeters, just lightened to the sternoclavicular joint is given, and after making an incision, we make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial still. One should take his own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense nailing after close reduction or mini incision reduction. So the immediate course of pain management and immobilization, after 2 weeks we did suture removal at 6 weeks, radiographic assessment of the fracture area, and 12 weeks the functional assessment, and if required, the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bite, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic nailing, beautiful surgery without use of any instrument. The reduction has been done by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, yet another case of the 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B1 fracture treated by titanium elastic nailing. These are the 15B2 fracture. This is 15B3 fracture treated by titanium elastic nailing. Ideally, it should be treated by open reduction and internal fixation, but we did tense nailing, and you can see the 6-month follow-up, the beautiful radiological union. And this is the functional result. You can see. So time is less. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up period and retrospective design. So a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of displaced fracture of the take-home message is TENS nailing is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further study are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science. 17 years old man. The road traffic accident was the mechanism of injury, clinical presentation, severe pain and deformity, and inability to bear the weight on the right side, whereas the left side he had a garage fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which we called the garage fracture and dislocation. And this is the X-ray of the femur, the sharp femur, the mid-third fracture of a 17-year-old gentleman, and the forearm garage fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was different. The standard treatment is nailing. And ideal treatment for this garage fracture is the plating, but I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the TENS nailing for garage fracture, and this is not reported in any literature for the such a severely displaced fracture. The TENS nailing should be considered. In fact, there is no literature present for the TENS nailing for this type of garage fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail and technique was minimally invasive, and whereas in this left radius, the garage fracture, we did TENS nailing. In this case also, the 2 millimeter TENS nail was used. Usually you use a 2.5 millimeter TENS nail, but we use 2 millimeter TENS nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal, but this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for garage fracture. So, but I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 months. You can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors have been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union. But This is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension are present. And the tense swelling is provides sufficient stability for secondary union even in critical fractures. Because the narrow canal and the length should be maintained to and DRUJ should be reduced properly. We followed throughout 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for gallagly fracture and femur is the minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirms that interlocking nailing of femur and TENS aids higher union rates and excellent functional outcomes. This approach should be considered for gallagly fracture in adult after further studies, because I think this is the first case in severe gallagly fracture I did TENS. So this case was published in International Journal of Orthopedic Sciences. Provides stable fixation and earlier mobilization and reduces the risk of non-union and malunion. TENS is less invasive, resulting in smaller incision. Conducted a study between March 2020 to March 2025 on 25 cases of the displaced fracture of the clavicle. The age of the patient was 16 to 48 years and no comorbidity was found in our study group. All patients treated with titanium elastic nylon. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in the mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a Z type of fracture, Z type of comminuted fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. 15B1 is a spiral and oblique, whereas 15B2 is the transverse fracture. So the patient lies supine with affected limb elevated and hanging outside the table so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is the very crucial step. And then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nailing was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb at the 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 week. The 6 month final follow-up with the 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 16% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail bite count, superficial infection, and malunion each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases. The radiological as well as clinical picture, as you can see, this is 15B1 fracture. And treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the one stitch surgery, no instrument was used to reduce the fracture, only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did the 15B1 fracture again treated by titanium elastic nailing. You can see the 6 month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site there is secondary callus formation. One bump is due to secondary callus formation, and other at the entry site you can see that there is hardware from this. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with the plate and screw. But we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6 month follow-up period. So this is the functional result. And the limitation of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS nailing is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here. ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापैटलर नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैलिएबल गाइड वायर को CR के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे CR के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। अब नेल को फाइनली लोअर एंड ऑफ द मेडुलरी कैनाल डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है RCT नेल इंट्रोड्यूसर कंपोजिशनर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से CR के मदद से गोल करने के बाद होल को गोल करने के बाद इस तरह से CR को एडजस्ट किया जाता है कि होल गोल दिखे और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है, अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। फाइनली दोनों स्क्रू को उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को। और अब लोअर फ्रैगमेंट के एंट्रोपोस्टेरियर जो होल है उसको गोल किया गया है। इस तरह से CR को एडजस्ट किया जाता है कि वो गोल दिखे। और एंट्रोपोस्टेरियर स्क्रू को डाल दिया गया है, जैसा कि आप पिक्चर में देख सकते हैं। अब देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है। इस तरह से CR को एडजस्ट किया गया है। और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला। Hello friends, today I am going to give a demo of interlocking nailing in fracture shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the shaft femur. So this time the patient had come to me for the lower third fracture of the shaft femur or other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeter diameter, and then after blood dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the piriform fossa in AP view. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am having the bone out inside the intramedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the every view, it has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3, at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. So after confirming it, I am going to introduce a introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make an space in the lateral part of the bone out to introduce the guide wire. And finally, after introducing the guide wire, we remove this bone out, and then after reduction of the fracture with the help of the F tools, my assistant is holding this fracture in proper position, and the guide wire has been introduced in the distal fragment. And after introduction of the guide wire, we are going to ream the medullary canal with the help of 9 millimeter reamer, and it is being reamed with 9 millimeter reamer, hand reamer, and it has crossed the fracture, and my assistant is keeping the fracture in reduced position throughout the nailing process with the help of the F tool. During nailing process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. I am doing reaming with a 10 millimeter reamer, and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, the slightly distracted, but in reduced position, in amplitude, and also in lateral view. This is the oblique view. And after performing in the CR, in both views, we did reaming up to the lower end of the femur, and finally we reamed this fracture with the help of power ream of 11 millimeter. Because the patient is old one, so reaming is easy. It is just to measure the size of the intramedullary canal, the diameter of the intramedullary canal, so what size of the nail should be introduced so that it can fit in the intramedullary canal. The fitting nail can be introduced. So this is the purpose of reaming, because the patient is old one osteoporotic. Throughout the nailing process, reaming process and nailing process, the fracture is kept in reduced position by my assistant, and the fracture has been reamed up to the lower CR picture. You can see the CR picture. It is reduced, although there is slightly distracted, but in reduced position. And finally, it has reached up to the lower end of the femur. And now I am measuring the size of the nail with the help of the CR. And after selecting the proper size of the nail, I have mounted a 10 millimeter, a 11 millimeter, sorry, 11 millimeter nail on cheek. Before proximal locking, and now I am doing proximal locking after removal of the guide wire. So you must keep in mind that before locking you have to remove the guide wire. And I am doing proximal locking. The proximal hole in the proximal fragment near cortex is perforated with the help of 2.5 millimeter K wire, and the distant cortex is drilled with 3.2 millimeter drill bit. We select the proper size, 5 millimeter screw for proximal locking, and I am still making a hole in the proper size screw has been tightened in proper position. And technique, I will make the hole circular as you can see in this picture. And both the screws has been tightened and confirmed in every and lateral view. The size of the screw is confirmed in the every view, and whether it is inside the hole or not, it is confirmed in lateral view. The size of the screw is slightly larger than it should be, but it was accepted because the effect of anesthesia was real. Now I am closing the wound after forceful wash of the wound. Now the wound has been closed. And the surgery is over. So thank you to my assistant, my anesthetist, and all the supporting staff for successful surgery of this 72 years old female for fracture sharp femur, which had been operated on the other side elsewhere 4 years back. So this is on the whole a successful and well-executed surgery. Thank you. Hello friends, I am Dr. R.C. Thakur, orthopedic surgeon, Sapra, Bihar. Today I will give a demo for, then I am confirming this whether this bone owl is entering at correct selected point or not in CR picture. So I am introducing the owl in correct position after confirming the entry point in CR picture, both in empty and lateral view. So this is the empty view. It is entering in proper selected position, and this is inside the intramedullary canal in correct position, going medially in empty view, and this is hammered, and the guide wire is entering. This is for the measuring the size of the intramedullary canal, diameter of the intramedullary canal, to select the correct size of the EFN A2 nail. So, but this is for measuring the intramedullary canal, and I am reaming by number 10 and then number 11 remove, and the size is 11 millimeter diameter PFN A2 nail selected, and then I am reaming with a 15 millimeter reamer because the upper part of the nail is about 15 millimeter diameter. So I am reaming this, and my assistant is pushing the reamer sleeve medially so that it goes in correct position. So it has been reamed with 15 millimeter reamer, and for introduction of the spiral blade, and this is the buttress nut. My assistant is tightening it, and so that it touches the lateral wall of the femur, and then I will introduce a guide wire sleeve, and a hard and stout guide wire is being hammered in the central position of the size of the nail selected. So I have reamed up to the proper distance, and now I am hammering the spiral blade after confirming it central position in both view, and I am compressing this spiral blade by clockwise movement, and so I am compressing the 2.5 millimeter kind of size of a screw for distal locking. I am measuring this on the CR. I am measuring the size of the, and now I am tightening the screw, distal screw. The final tightening is done. So confirming in CR picture. The final tightening is being done now. It has been tightened. And now my surgery is over, and this is the happy view. You can see that it is in good position, and this is the lateral view of distal screw. It has been introduced in proper position in the hole, and this is the lateral view. The spiral blade has gone in the central position in lateral view also. So I will give a forceful wash of the wound, and finally I will stitch the skin and close the wound in layers. And I am closing the wound. The design of the spiral blade provides a stable fixation, and we can mobilize the patient from second post-operative day. So this is the lateral view, and this is the AP view post-operative. So thank you everybody. My understanding is thank you everybody.
Hello friends, I am Dr. RCT Ortho, orthopedic surgeon, Chhapra, Bihar. Today I am going to present my innovative work named Dr. Thakur Innovative Technique of Suprapatellar Nailing of Tibia. Tibial fractures are most common among the long bone fractures in human body. These are usually caused by high energy trauma like a fall from height. Study shows Dr. Thakur innovative technique of suprapatellar nailing of tibia is safe, cost-effective method of treatment for metaphyseal tibial fractures. Intramedullary nailing technique is the 100% satisfactory union of fracture in safe and cost-effective way. No special instrument or jig are required. A protective slip and a trocar can be used from PFN A to Z, and color-coded infrapatellar tibial nail extractor can be used to introduce the nail in proper position. Between March 2020 to March 2021, Dr. Thakur innovative technique of suprapatellar nailing of tibia conducted on 25 patients to fix their tibial fractures. The patients how Dr. Thakur innovative technique of suprapatellar nailing of tibia done. It is done in semi-extended position, about 20 degree of flexion at the knee joint, either transverse or longitudinal. We are introduced after severe bleeding, fracture reduction, and confirmed by fluoroscopy, mounting of the nail with appropriate size over the color-coded tibial nail extractor done. Introduction of appropriate nail size over the guide wire done in proper position with the help of color-coded tibial nail extractor. Locking both proximal and distal done by freehand technique. No jig were used. Wash percutaneous reduction with the reduction forceps in AP view, and this is in lateral view. Nail entry over the guide wire and nail entry in distal fragment in AP view. Nail entry post-op, we started partial weight bearing. 12 weeks after operation, we started full weight bearing. Now, the final observation, operative time, return for follow-up, telephonic follow-ups, we are done and called for follow-up in hospital. No complication, we are observed, no patient experienced any loosening or breakage of a screw or nail, no one complaint of knee pain, no reduction loss or significant displacement of fracture occurred after surgery. Final follow-up, 21 cases found excellent and 4 good results. In none of the patient, removal of nail was done for any cause. These are the results. Tibial fractures, AP and lateral view, post-op, and this is the clinical pictures, 3 weeks follow-up, 3 weeks after the surgery. Duration of this surgery, the number of cases included in this study was small. The study was not comparative with the standard technique. The status of cartilage over the patella and trochlea post-surgery has not been evaluated. Thus, furthermore study with larger population and long follow-up time is required to compare this innovative technique with a standard technique of suprapatellar nailing. In this technique, fluoroscopy time was slightly more than the standard technique because both distal and proximal locking were done by freehand technique. If the only disadvantage of this technique is the slightly more radiation occurs because the proximal and distal TB. Thank you. The number one myth is interlocking nailing of humerus will severely impair the shoulder function due to rotator cuff damage. The reality is, with proper technique and entry point, the rotator cuff damage can be minimized and shoulder function can be preserved. So the myth number 2 is there is always chance of radial nerve injury as it is a complication for the interlocking nailing of humerus. It is not a complication for the open reduction and internal fixation for plating. So it is, yes, it is, there is risk of radial nerve injury when the fracture is at the spinal root. There is chance of the radial nerve injury, but in the rest of the part, if the fracture is in the rest of the part of the humerus, there is minimum chance of the radial nerve injury when the instruments like the guide wire, remove, and the nail is introduced after proper reduction of the fracture in the distal fragment. Both AP and lateral view, the fracture is reduced properly. Only then these instruments are introduced inside the distal fragment. And don't allow your instrument to wander inside the soft tissue.
So these are the two myths which is associated with interlocking nailing of humerus, and other two controversies whether which position of the patient should be used for the interlocking nailing of humerus. There are three positions. Number one, supine position. When it is used, it is comfortable for the anesthesia point of view as well as the surgeons. But the distal locking, which is done by freehand technique, is slightly difficult and tricky because the anterior surface of the distal part of the humerus is triangular. So finding the entry point for the distal locking is slightly difficult because slipping of the dilbit or KY. So it should be at angle, it should be introduced at angle, and then it should be kept in a straight line. So this is the disadvantage of supine position, and in lateral position as well as the prone position, the distal locking is done from the posterior surface, which is flat. So the entry hole, finding the entry point for the distal locking is easy because the surface is the flat, but it is uncomfortable position for anesthesia point of view, and the surgeons, it depends on the surgeon's choice. So I do use supine position for all my interlocking nailing. Number three controversy is because it is non-weight bearing bone, so one screw distal and one screw proximal is sufficient. But I use two screw distal and two screw proximal because the two is always better than one, always stronger than one. If it is just like the two kidney present in human body, if one fails, others start working. So, and two engines in the aeroplane, one engine fails, the other start working automatically. So, if one screw is not working, then the other screw will do its work. So, the fixation is better by two screw proximal and two screw distal. So, friends, these are the advantages of interlocking nailing over the plating of the humerus, and these are the myths, and these are the controversies whether two screws should be put proximal as well as the distal, what position should be used in this talk, and let us get tuned for the next video and subscribe my channel for more update on orthopedic surgery and insight.
Yeah, I am Mr. Prashant.